Hello everyone, welcome to KGMOA Kozhikode CME series. Today let's talk about nutritional anemia in children. Anemia, that is reduced hemoglobin in the blood, is a major public health problem affecting around 1/3 of world population. And in children, most common cause of anemia is nutritional, and most common cause of nutritional anemia is iron deficiency. So in today's video, I am mainly talking about iron deficiency anemia in children. We know that iron is needed for hemoglobin synthesis or RBC synthesis, which carries oxygen to different parts of the body for their function. Though the central action of iron is hemoglobin synthesis, it has got a lot of other metabolic functions. Like it helps in DNA synthesis, then myoglobin in the muscle contains iron. That's the reason for muscle pain or cramps in iron deficiency due to reduced myoglobin. Then iron has got immunological functions. It helps in T cell maturation and antibody formation. So iron deficiency can cause reduced immunity leading to recurrent infections in children. Then iron has got cognitive functions. It helps in myelin synthesis and neurotransmitter synthesis in the brain. So iron deficiency can cause impairment of this neurotransmitter and myelin synthesis, and child may develop irritability, poor concentration and poor memory, reduced scholastic performance. All this can happen when there is iron deficiency. And studies have shown that this iron deficiency can cause even irreversible or permanent damage to the brain if not treated or if not detected early. Now what happens when there is iron deficiency? Our wonderful body compensates for this iron deficiency. There is increased release of oxygen from hemoglobin to the tissues. There is increased cardiac output and redistribution of blood to the vital organs. So in the initial stage, there won't be any clinical manifestation, there won't be any anemia, hemoglobin level will be normal. But beyond a limit, what happens? Our body gets exhausted. It can no more compensate for this iron deficiency, and there comes the stage of iron deficiency anemia. At this stage only, hemoglobin level starts decreasing and clinical manifestations occur. So that is the dangerous thing in iron deficiency anemia. It's very difficult to detect the initial stage of iron deficiency, and this iron deficiency can cause even neuronal or brain damage even before the anemia develops. So the only thing we should do is preventing iron deficiency than treating iron deficiency anemia. So how can we prevent iron deficiency? We used to advise parents like give iron rich foods to the children like green leafy vegetables, sprouted veggies, beans, then ragi, rice grains. But the problem of all this so-called iron rich food is that though they contain a lot of iron, we don't get all these iron to get utilized by our body because of the presence of inhibitors in these food items which inhibit iron absorption. And on the animal-based food, even egg yolk contains an inhibitor of iron absorption, and cow's milk contains calcium, which is an inhibitor of iron absorption. So the only animal foods which are good source of iron are meat and fish. And one important vitamin which enhances, which stimulates iron absorption is vitamin C. So taking vitamin C rich foods like citrus fruits can increase the iron absorption of other food items. And in children, iron deficiency anemia usually occurs after 6 months of age. Before 6 months, human breast milk is sufficient to give enough iron to the baby. But after 6 months, in India, we usually give plant-based food as complementary feeds. We introduce animal-based food very late, so they are more prone for developing iron deficiency anemia. Other high-risk groups are adolescents because of increased iron requirement due to rapid growth spurt and menstrual blood loss. Then pregnancy, lactation, all these are high-risk groups who are more prone for developing iron deficiency anemia. Another important cause of iron deficiency is worm infestation, especially hookworm infestation, which can cause iron deficiency due to blood loss. Now, how do we diagnose iron deficiency anemia? Clinically, we look for pallor. In young children, we look for pallor in palms and soles, nail beds, tongue, oral mucosa. In older children, we look for pallor in lower palpebral conjunctiva. Now, the lab diagnosis includes detecting hemoglobin level. Hemoglobin level will be reduced to less than 11, and we can classify anemia based on this hemoglobin level. We don't need to by heart all these values, but one thing we should know is what is severe anemia. Severe anemia in children less than 5 years is HB less than 7, and more than 5 years it is HB less than 8. This we should know because if there is severe anemia, we have to immediately refer the child to a higher center. So severe anemia means less than 5 years it is less than 7, more than 5 years it is less than 8. Now other parameters like MCV, MCH will be reduced, RDW, red cell distribution will be increased in iron deficiency. But the HB, hemoglobin level, is the least sensitive indicator of iron deficiency, because we know that HB level declines only in the late stage of iron deficiency. So what is the single most sensitive indicator of iron deficiency? It is serum ferritin. Serum ferritin denotes the storage form of iron. We know that the iron storage gets depleted in the initial stage of iron deficiency. So serum ferritin is the single most sensitive indicator of iron deficiency. But the problem is we don't routinely do all these tests at PHC or CHC level. So what we can do at peripheral level to prevent this iron deficiency? So again, I would like to emphasize some points. One is, it's very difficult to detect iron deficiency in the initial stage. Then iron deficiency can cause neuronal damage even before anemia develops. Then dietary modification alone cannot compensate for iron deficiency as we expect. Then hemoglobin level is the least sensitive indicator of iron deficiency. So what is the best thing we can do to prevent iron deficiency? Is just give iron supplementation, and that is known as National Iron Plus Initiative or Anemia Mukt Bharat. Here we give iron to all the children 6 months to 19 years of age, and also to pregnant and lactating mothers irrespective of their hemoglobin status. We don't look for hemoglobin level, we just give iron to all the children irrespective of their hemoglobin status. And here we give iron only in the supplemental dose, not in the therapeutic dose. So it's a very safe but at the same time very effective method of preventing iron deficiency anemia. So how do we give this supplemental dose of iron? This is the most important part of today's session. So first we divide the children into different age groups, and for children 6 months to 5 years we give IFA syrup. This is the government supply of IFA syrup. It contains 1 ml of the syrup contains 20 milligram of elemental iron and 0.1 milligram, that is 100 microgram of folic acid. And this syrup has got an auto dispenser. I hope you can see this auto dispenser. And when we press this bottle, this syrup gets filled in this auto dispenser. And advantage of this dispenser is that only 1 ml of syrup will be dispensed at a time, so as to prevent toxicity. So for children 6 months to 5 years, we give 1 ml of this IFA syrup bi-weekly, twice weekly. And along with IFA, we give biannual deworming, that is albendazole. The dose is less than 2 years, it is 200 milligram. More than 2 years, it is 400 milligram. Now for children from 5 to 10 years of age, we give IFA tablet containing 45 milligram elemental iron and 0.4 milligram folic acid. We give this IFA tablet weekly along with biannual deworming. Now for children from 10 to 19 years, we give IFA tablet containing 100 milligram elemental iron and 0.5 milligram folic acid weekly along with biannual deworming. So this is the prophylactic dose of iron. For children 6 months to 5 years, we give 1 ml of IFA syrup bi-weekly. For children 5 to 10 years of age, we give 45 milligram elemental iron weekly. And for children 10 to 19 years, we give 100 milligram iron weekly. So this is the prophylactic dose of iron. And evidence suggests that this weekly regimen is as effective as daily regimen with much lower side effects. Now coming to the treatment of iron deficiency anemia, that is therapeutic approach through the life cycle. We know that anemia is a major public health problem with the global burden of anemia is humongous. So it's very important to treat iron deficiency anemia to prevent its complications. So here we advise our field staffs, ASHA workers, Anganwadi workers to look for pallor in children and to refer the children to us if they are found to be anemic. And if they are clinically found to be anemic, we have to check for hemoglobin level. If there is severe anemia, we have to refer the patient to a higher center. Then other indication for referral is along with hemoglobin, there is impairment of other blood counts like total count, platelet. Then along with pallor, there is hepatosplenomegaly, lymphadenopathy, then family history of anemia. Then the other indication is no improvement after iron treatment. So these are the indications for referral of a child with anemia to a higher center. So the treatment doses, therapeutic dose of iron to all the children is 3 milligram per kilogram. 3 milligram per kilogram iron daily. That is the therapeutic dose. For older children, more than 10 years, without calculating this 3 mg per kg, we can just give 60 milligram elemental iron daily. So after starting this iron, we can see the clinical improvement within a week. The appetite improves, irritability decreases. Then we have to repeat the hemoglobin level after 1 month of treatment, and there should be an increase of at least 1 gram per deciliter hemoglobin after 1 month. And we should not stop iron treatment when the hemoglobin level becomes normal. We have to continue the treatment for around 4 to 6 months in order to replenish the iron stores. So the total duration of iron treatment is 4 to 6 months. So the take home message from today's section is that 1. It's very difficult to detect iron deficiency in the initial stage. Hemoglobin level estimation is the least sensitive indicator of iron deficiency. Iron deficiency can cause neurological damage even before anemia develops. So the best thing is to give iron to all the children irrespective of the hemoglobin status. And any child presenting to us with any illness, we have to look for pallor, and if found to be anemic, we have to check hemoglobin level, and if there is anemia, we have to treat accordingly. So by just giving iron, we can make wonders in our children's life. Thank you.